The recording will be available within 24 hours of the meeting, and there will be a link on the MaineCare website that directs you to where that recording will be located. So I will go ahead and turn it over to Michelle to do the introductions from MaineCare.
Great, thanks, Julia. Hello, everybody. It's really exciting to see such a robust crowd here this afternoon. I can't actually see anybody, but I can see the number, and so 100 participants is great. My name is Michelle Probert. I am director for the MaineCare program, and I would like to ask Peter Kraut to introduce himself as well.
I'm Peter Kraut, MaineCare's rate setting manager.
And I will also mention that we've got a few folks from the MaineCare policy unit, including Heather Binglis and Henry Eckerson. We also likely have folks from across the department who are on the call as well, but I can't see them on the list because the attendees are blind to me right now. But they're out there, I can assure you. So I will just jump right in to really why we're here today. We, as the Office of MaineCare Services, have been excited about this project for quite some time now. And now that we have Myers and Stauffer on board as our vendor, it's great to have the work underway, and especially for us to be engaging in our first round of stakeholder engagement this week. And we can go to the next slide, please. So the purpose of the broad rate system evaluation that we are conducting right now, there's two main areas to simplify it. And we all appreciate, and I'm sure you all as providers definitely appreciate the fact that rates are foundational to the care that you provide so that we can make sure that members have access to critical services. And if rates are not adequate for you to deliver your service, that means that our members are either not getting the level of quality care that they deserve, or they might not be getting the care at all. And so we want to make sure our system, which is currently very complex, it is not very consistent, and it's a challenging system. So number one, ensuring that our rates are adequate to provide care. We also want to make sure that the way we pay for services helps to incent high quality care and cost-effective care. And then lastly, in terms of administrative simplicity, both in terms of providers being able to understand our system and also for MaineCare and the department to administer the system, we are looking forward to having a more rational, streamlined, coherent rate setting system as a whole. Next slide. So the purpose of today's meeting, as I said, this is our first round of stakeholder engagement. We will be having a second round of stakeholder engagement in about another month. We are working to finalize dates now. This round of stakeholder engagement is focused on how we pay for care, not what we pay for care. So today we are really looking for your input on the impact that our reimbursement methodologies have in terms of the administrative work that you have to do, the impact on services you provide or perhaps don't provide, and any potential impacts on the patients and clients you serve themselves. Our next round of stakeholder engagement is when we are going to be getting your feedback on how much we pay. And we will be getting a report before that next round from Myers and Stauffer that we are referring to as our benchmarking report. And it will do a couple of things for all of MaineCare services. It will look at how we compare to other state Medicaid agencies, to Medicare, and to commercial insurance in terms of our rates, as well as our rate methods for comparable services. And that's not going to be perfect information, but it will give us an idea of where we may be outliers, both on the high side as well as the low side. So it'll be, it's a report I've been dreaming of for a long time, and I think it'll be really instructive for all of us. So once we have, not yet, you can go back. So once we have that report, that is when we are going to be engaging in our second round of stakeholder engagement, and with more of a focus on hearing from members as well. And then I just wanted to state that the purpose of today's meeting, aside from this short little intro, is to really hear from you. So this is not the forum for us to answer questions. It's really for us to hear from you about impact of reimbursement methodologies. Okay, next slide. So some of the questions that we shared in advance have to do with value-based purchasing. And that's something that we think of a lot at MaineCare and within the department, but I recognize that not everybody goes around thinking about value-based purchasing on a day-to-day basis. And so we thought it might be helpful just to give a very high-level brief overview of what we think about when we say value-based purchasing. And the first thing that I always like to level set on here is how we're defining value, because it's a term that people use a lot without necessarily thinking about what the definition of value is. And by definition, value is the relationship between quality and cost. And those are two really critical things in healthcare right now. And again, this is probably an oversimplification, but I find it helpful to think, like, what are two of the main ways we can improve the value of the care that is provided? And at a very basic level, if you hold quality constant, the way you improve value is by decreasing the cost. If you hold the cost constant, the way you improve value is by increasing the quality. And so the relationship between the two is key. And we want to do a better job of making sure that the way we pay for care is helping to better ensure high value care. And what we do know is that with a fee-for-service system where we are just going to pay you for volume regardless of how quality or cost are doing, is not reaching that goal. Next slide, please. All right. So we have a number of programs currently where we are purchasing in a value-based manner, and we have an explicit goal of increasing our reimbursement that utilizes value-based purchasing. So right now, our estimate is that about 20% of MaineCare dollars goes to reimbursement that is value-based. We have a goal by the end of 2022 to almost double that percentage to 40%. Next slide. And another phrase that you might hear from us in terms of value-based purchasing is alternative payment models. So alternative payment models are the specific ways to reimburse for care that really get us to the goal of value-based purchasing. And there's a great organization, you can see their logo at the bottom of this screen, called the Healthcare Payment Learning and Action Network, or HCP-LAN. And they, over the past number of years, have done some impressive work with stakeholders across the country so that we in the US can have a common understanding and definition of what alternative payment models are, what the continuum looks like from, on one hand, fee-for-service, that again has no relation to cost or quality, to the other end of the spectrum, where we're really talking about population-based payment that has strong links to quality, that has the benefit of being a much more flexible system that, for example, could be much more responsive to a pandemic, and that also puts some onus on providers and not just on purchasers and entities like Medicaid for the cost of that care. So there, again, it is a continuum. The first step in the process is often to take at least a portion of payment and say that we are going to tie the payment of this portion of payment for your services to actual quality outcomes. And then from there, you can get into more flexible payment models and models that look at accountability for an array of care for populations, et cetera. All right, so again, that is a very brief high-level overview of value-based purchasing, but I hope that it was helpful. Again, thank you for being here. We're up to 120 participants. That's great. And I am going to hand things back to Julia. She is going to talk through the discussion topics for this afternoon, as well as our general rules for engagement. And I am unfortunately not able to stay with you this afternoon, but I am very much looking forward to hearing about the comments that you share with us today. So thank you very much. Julia.
Great, thank you so much, Michelle. So these will be the 5 questions we'll be asking. Will be organized by question. So we'll put up a question and ask everyone who would like to participate to raise your hand. If you go ahead and advance to the next slide, Jillian will kind of walk through how we're going to manage this. So our role is really to introduce the discussion questions. We're kind of grouping it at around 30 minutes per question. Some questions have taken a little bit longer, which is fine. But we do have a lot more participants at this one than we've had in the past. So we may ask people to be a little quicker about their comments or keep them to a reasonable length of time so we can make sure everyone participates. We've had the email up a couple of times where you can send us written comments if you'd like to. We're always happy to accept those. As we said at the beginning, the meeting is being recorded and we'll transcribe it. The recording will be up within 24 hours. We're really going to ask you to introduce yourself and your service. That helps us to take better notes so that we know who you are and what specific service you're speaking to. In order to speak, we're going to use the hand raising method. Above your chat box, there will be a symbol that kind of looks like a little hand. That's the actual hand raising. Next to it is a megaphone looking symbol. So if you're having trouble finding the little hand, it's right next to the megaphone. If for some reason you can't find your hand or the hand isn't working, the raise your hand function isn't working, you can type in chat and Jillian can see the chat and she will go through people who've raised their hand and people that have chatted in order to unmute everyone one at a time. We ask that you sort of stay on topic with the discussion topic that's being discussed. When you're done making your comment, if you could unclick your hand and then we know you've dropped out of the queue, and that will make it a lot easier for us as we organize these around question to question and that you know where you're asking to speak or not. Please respect the time limits for each comment. We really want to hear from everyone and limit the comments to those related to the impact of the payment methodology and not specifically about rate amounts. If you could go to the next slide, please. So just a couple of reminders. We're going to have the phase 2 meetings that will be more about the phase 1 report, which will include benchmark rates and catalog of existing payment methods, as well as recommendations for APMs. And at that stakeholdering, we will be talking more about the actual rates. You can submit written comments at any time to ratesettingeval@maine.gov. If you don't wish to speak or if you don't have time or if you want to add more clarity to what you said, we're happy to accept written comments. So we'll go ahead and start with the first discussion question. This is really about your perceptions of your methodology. Is it transparent and easily understandable? Does it create opportunities for efficiency and economy? one thing, we're looking at is, does it reflect how you deliver services? So if you typically provide a bundle of services, but you have to bill separately for each of them, or you're billing 15-minute increments, but your service is typically 1 or more hours. So anything like that you'd like to share with us about how the current methodology is working for the services you provide. So at this point, I'll go ahead and ask everybody to please raise your hand if you would like to offer a comment so that Julie can start moving through the list. And also, again, if you can't raise your hand, please don't hesitate to type in the chat so that we can find you there as well.
Okay, thank you, Julia. First, I have Rebecca Emmons.
Good afternoon. Can you hear me okay?
Yes, we can hear you.
Okay, great. Thank you for the opportunity to provide input. I'm here today. I am the Executive Director of Mobius, based in Lincoln County, but my comments represent members of the Maine Association of Community Service Providers, MACSP, our statewide trade association. The payment methodology for specifically sections 21 and 29 community support services is transparent, as the rates are publicly available. The community support services allow right now for an average group ratio. There is no published methodology for how a provider should measure this average group ratio. The ratio, however, around 1 staff to 3 members as an average is a strength in the current methodology, and this flexibility is absolutely crucial to support both economic sustainability as well as program efficiencies. Community support services are administered through approved units within a financial service cap. The units are calculated through what's called a state-provided Section 21 and 29 rate calculator. There is wide variation in the case management use of the calculator when facilitating the person-centered planning process, and so that could impact equitable access to the service as well as allocation of those units. The calculator is a secondary resource that is not widely available to members, constituents, other stakeholders, and therefore lacks transparency and consistency. In terms of administrative burdens, efficiencies, and economy, the receipt of the summary of authorized services, or auths, for services to be provided are received sporadically and lack a predictable cadence, creating exceedingly difficult administrative burdens for providers to keep up with both the data input as well as when to anticipate a new auth. The MaineCare Benefits Manual outlines this service on an annual basis, and that's the cadence to the person-centered planning process. And an efficiency could be found if services could be authorized for a 12-month cycle rather than sporadically within a 6-month cap. A methodology to inform rates should be created for individuals with challenging behaviors, or those who have active positive behavior support or behavior management plans. These members need a specific type of safety care and specially trained staff, regardless of their setting, whether their community supports are provided in a facility or in a community setting. If a one-on-one rate were to be available for these individuals for their community support services, that rate should stand regardless of the setting in which the service is provided. Similarly, individual members who have medical, behavioral, feeding, toileting, speech, occupational therapy, the list could go on regarding the individual complexities. If they were to have a lower rate if a lower rate were to be included in the methodology for facility-based services, these individuals are more likely to need facility-based service, and their access to the services would be difficult. That concludes my comments for these 3 bullet points.
Thank you, Rebecca. Next up, I've got Catherine.
This is Catherine Thibodeau from Independence Advocates of Maine. I'm the Executive Director. I'm speaking on Section 50. I'm also speaking representing Maine Association of Community Service Providers, MAXPE. I serve on the board as the secretary. I also am the chair of the ICF committee. MAXPE represents 11 of the 16 ICF homes within our state. To speak to the questions, the payment methodology, the rate methodology for Section 50 services, we believe is transparent. There's a very complex principles of reimbursement that is easily understandable and available to all providers. The one thing that, or one of the things that is important when looking at the rate methodology for this program is to understand that this program serves only 192 Mainers. They all have IDD and they all have very complex medical and behavioral challenges. There's 16 homes in our state that range from the top of the state to the bottom of the state, east to west. And because it is a congregate type of setting, there's an economy of scale. These individuals have very intense needs, and really is probably the most important thing in analyzing the rate methodology is having a very good understanding of their needs. An example of a ICF facility, not the one that we operate, but another one of the MAXPE members that is representative of this service sector. This is a 14-person home. They administer over 9,000 medications a month. That's not including any PRN medications. All of their residents are dependent on 100% of care for ADLs. All of their residents have 8 or more diagnoses. All of them are nonverbal. 90% of them have feeding tubes that they get their nutrition through, and 100% of them have dysphagia. That's very typical if you look across the sector. So one of the things that we have looked at over the years is what the cost of this service would be if it was provided on an individual or in a 2-person type setting, and that cost is quite a bit much more than it's being paid now. Another sort of thing to note about this population of people is their healthcare costs in general nationally is about 12 times the average person's healthcare. So I think that is very important when you're looking at the rate methodology. The rate is set up, it's a cost reimbursed service, and it's a daily billable rate. This is pretty well reflective of how services are provided. It is, we do not have a lot of movement necessarily in and out of the program, but it still is efficient enough to be billed on a daily rate. It's a bundled service, so you get one rate for all of the services provided within the program, other than the day habilitation service, which is billed separately. That has worked well. Anything different from that would become very, very complex. It's a highly administratively burdensome rate reimbursement, but as a provider community, we believe that is important. We believe due to the cost of the service, it is important that every cost and every dollar is accounted for. And so we do not have an issue as a whole in the level of administrative burden. And I think that's all on those 3 questions.
Okay, thank you, Catherine. Okay, I'm not seeing any other raised hands on this section or anything in the chat. I do have a few call-in users that may not be able to use their chat. And I did have one note that someone had a problem with the hand. So let me unmute. Okay, Ray.
Hi, can you hear me?
Yes.
I'm Ray Nagel. I'm the Executive Director of Independence Association, and I'd like to talk about per diem home supports under Section 21 in particular. I believe that the rates are posted, and we have access to the rates. The rate methodology is unknown to the general user. The rate methodology was done in 2005 and adopted in 2007. By contract, and that rate is still that formula is still the rate by which we're paid, and the increases and decreases to the rates that were paid have nothing to do with the original formula. So that's a problem, because that was actually put into law. The other thing is, I do not believe that members of ODS and MaineCare understand the rate methodology, and various providers have had to teach them how the rate methodology works, and there hasn't been any type of discussion regarding how to back in today's rates into that original formula. The rates, and the rates for DSPs, as mentioned a little bit earlier in that formula, are they amount to less than minimum wage, but we're going to talk about that at a different time. The rates as published are skewed because they include a 6% provider service tax, which has to be paid back the month after you receive the reimbursement. The original CMS approved rates for individuals in Section 21 had an incentive to work with people that had challenging behaviors, called a behavioral add-on. That has been removed. And it's really important to bear in mind when you're looking at rates and rate methodologies. Most states across the country have institutions, and those institutions are funded by the federal government and typically monitored by AHCA, the Agency for Healthcare Administration. And other states make significant more use of intermediate care facilities for the developmentally disabled, which in Maine are extremely limited. So when you're looking at your rate settings and looking at methodologies and doing comparative analysis, you have to bear in mind that Maine has no institutions and very few ICFMRs comparatively. So the cost per capita and our home and community-based waiver budgets per person are higher per capita than other states. The other thing that is used for rate methodology is fiscal effort. And in Maine, when you look up the definition of fiscal effort, it's the amount of money used to fund Medicaid as compared to the relative income of the people of the state. And so we rank second behind New York, but that really basically just tells you that Maine is a very poor state. So I don't find it as a helpful tool. The per diem in group homes, we're paid on a per diem, which is a misnomer because per diem typically means by day. When Maine did their current contract with CMS, they arbitrarily included a 92.5% staffing ratio that must be met in order to get the full rate for the day. Otherwise, you're paid on an hourly basis. That puts extreme pressure on providers from an overtime perspective as well as administrative perspective, trying to keep up with those ratios. It also it encourages agencies to request more hours per person in order to get more money, which doesn't make sense. Because if it's a true per diem, the amount of money that you would get every day would be the same. And right now, it's treated as an hourly system that is per diem, if you will. And when you have that type of a system, it really encourages inflation of hours and doesn't allow agencies like mine to be able to staff at a consistent rate without having overtime to meet the 92.5%. And that's all I have.
Thank you, Ray. Next up, I have Eric Muckey.
Yeah, you pronounced that perfectly. Thank you. And thank you, panelists, for allowing us to speak. My name is Eric Muckey. I'm the business manager at the Developmental Services of Sweetser up here in Bangor. Ray pretty much touched on all the points I was going to speak to. We provide Section 21 home supports on an agency per diem model, which, as Ray mentioned, the per diem is a bit of a misnomer. Yeah, I wanted to bring up the fact that the per diem model based on hours, because it's sort of underwritten by hours, isn't very functional for the support that we provide, because when, for example, during day program, we're sort of penalized from a revenue standpoint if the clients do have and the residents do have day program, because we're more or less paying a substantial amount of fixed costs to maintain the homes, the group homes that we are providing to the clients. And so a true per day would be functionally much better and make more sense for how we provide our support. The second one I wanted to bring up was sort of the overall burden of administrative and oversight support that's required to, and Ray touched on this as well, maintain the documentation standard and sort of managing those ratios versus a true per diem where we could focus much more on just meeting the client's goals as opposed to staffing for the sake of staffing. And then the last point I wanted to make was there was the medical add-on, and I'm sure there's a few other things, but there's a lot of intricacies within the billing model for additional types of billing, such as the medical add-on, that is surprisingly convoluted and difficult to use. And I feel like if we were to remove the barriers to rates like the medical add-on and the previous behavioral add-on, I know it doesn't exist anymore, but if we could sort of create more of a universal rate, I think that would be much more accessible to most of the service providers. And that's all I had. Thank you.
Thank you, Eric. Next up, I have Anne Marie. It looks like you might be a call-in user, so bear with me as I try to identify you. Could you try and speak, Anne Marie? Okay, you're not any of those. Sorry, give me 1 sec. I'm working my way through.
If the neighbors call the police, it's going to be worse if we call the police.
Hey.
Marie, can you try to speak?
Hi, can you hear me?
Yes, okay. I was able to identify.
All right, thank you. My name is Andrea Mayberry. I am the executive director at in Westbrook, Maine. And I also sit on the MAXB board, which is the Maine Association for Community Service Providers, and represent residential. I do want to thank Ray. He did speak to quite a bit of the issues that I was going to raise, but I will reiterate a couple of them that I feel are very important. the methodology is transparent. However, it's not a true per diem. So there's some concern there on how people are using the term per diem when we are actually having to, we don't have that flexibility as a true per diem. When we bill under 92.5% for residential Section 21, we have to drop down to a lower rate, even though we're providing the staffing and the services. When we bill over 100%, when we staff over 100%, we're not paid either. And I know that for our agency and other executive directors that I've been in contact with, that happens more often than not, that you're billing over because of either the services you're providing or the training and meetings and special meetings and doctor's appointments, things that happen outside of the schedule that you're having to provide more hours that you are authorized for. Also, under does the methodology create opportunities for efficiency and economy? I don't believe so. I believe that Maine, since Maine does not have an institution, many of the consumers that are high behavioral, high medical, or diagnosed with both mental health and IDD are, some of them are sent out of state, and that cost is enormous. It's in the hundreds of thousands of dollars for people that are sent out of state to state institutions in Florida and Massachusetts. If we had a better rate methodology, one that paid for behavioral supports, we might be able to bring a lot of people that are out of state home and be able to service them here in the state of Maine with a better methodology, with a better rate. Just like if people were to compare the medical add-on that we have, that medical add-on, I know that our agency serves a large population of older adults that have significant medical health issues. And we have 2 nurses that are constantly in contact with staff and training them and keeping them out of the nursing home. They're keeping them out of the medical emergency rooms. And so, the state needs to look at that behavioral add-on to see how we can better provide for people that we support in a more efficient manner. Also, under the methodology, just throw this in, the nurses that agencies have aren't considered in that calculation. So that's just something I think that should be added to the methodology, is especially in the time of this pandemic that people are very heavily relying on nurses. There should be a rate portion in there for nurses. And I will say that the administrative burden for tracking the hours between the 92.5% and the 100 and under 92 and the on behalf of is heavy. It's extremely heavy. It's I would much rather focus our time and attention on the services and the support for the people that we provide services to. And it's only going to become more difficult when HCBS comes into full compliance. Thank you.
Thank you, Anne Marie. Next, I have a few people left. Next, I have Andrew.
Hi, my name is Andrew Cowan. I'm the Chief Financial Officer of Jonathan Murray Homes in the Lewiston Auburn area. My comments are on Section 21 in-home supports. And the primary comment is any consideration to a rate has to go hand in hand with the cost of room and board. I know the state considers the two to be separate, but what I've seen over my last 8 years is the state robs Peter to pay Paul. So we received a room and board subsidy from the state, probably about $140,000 when I started, and it's been cut in half. And that's essentially been done to rob Peter to pay Paul to save more people off the waiting list. So when you create a new rate model for in-home supports, you need to also consider the fact that in-home supports means that these people live in a home, and the cost of that home needs to be taken into account. So if we're not adequately reimbursed for the cost of room and board, the money's got to come from somewhere to provide that room and board. And so that money comes from the rate that is supposed to be meant to reimburse us for the actual in-home supports. The second comment I have is kind of piggybacks on a couple other people's comments. I believe there needs to be an additional rate created for on-the-job job shadowing. More often than not, because we have such high turnover, because our rate is so insufficient. We have constant turnover. People are job shadowing on the job, so we are having to overstaff in order to do that job shadowing. So if a separate rate were to be created for that job shadowing, we could split out a cost of training versus the actual cost of in-home supports. And that's all I have. Thank you.
Thank you, Andrew. I've got two more people with their hand raised up, and then we will be moving on to the next question. And then we can always come back if we have time at the end. So next up, I have Todd.
Todd Goodwin, can you hear me?
Yes, we can.
Okay, sorry, I'm a Luddite. I was looking for the hand to raise and took me forever. I'll try to be brief, and I apologize if I touch on things some other folks have said. I'll try not to. I agree with, absolutely agree with all the comments that have been made by folks preceding mine. I would just make, I'm with John F. Murphy Homes, I'm sorry, work with Andrew, based in the Lewis and Auburn area. We operate in about 5 or 6 counties, I believe. I want to just offer 2 very quick additional comments on the Section 21 agency home support rate, and it's related to some comments others have made. I would just note that methodologically, that rate model ties the rate to a staff hour as opposed to a client hour, which I think presents a whole host of challenges, as has been articulated by several others. So I think it's important to remember that. And then going back, if you were to go back and look at the original construction of the rate models for that service, you'll recognize, as others have noted, that rate intends to cover several operational factors in providing the service. And it is, I think, manifestly fair to say that the rate model as it exists now is structurally inadequate in the face of the assorted cost drivers that go into providing the service. That's not a comment on the dollar amount necessarily, because I know that's not our purpose here, but just structurally in the way it's constructed and what it's intended to hit at, it is inadequate to that task for all kinds of reasons, not the least of which is it does not respond to our state's minimum wage law. So thank you all for the opportunity. We're grateful that you're giving all of us a chance to join you in this, and appreciate the chance to make a comment.
Thank you, Todd. Next up with I think it's going to be our last comment for this section, I've got Pete.
Yes, thank you. This is, can you hear me?
Yep.
Okay, good. This is Pete Plummer from Woodford's Family Services. I'm not going to go through what everybody else said. I'm just going to add a couple small other things to that, but I couldn't agree more wholeheartedly with a lot of the testimony. And one of the things that we do when we bill for that crazy formula that we have to go through to add up all the hours and try to fall into the window and average it over a period of time, it's a lot of work. So we bill infrequently, we bill monthly. And I think that's common for a lot of people, because to fall within that window, takes a lot of, it's just unbelievable the amount of work that goes into that. And billing monthly, gives you more flexibility to try to fall in there. But what it does, it kills the cash flow of any organization. So the methodology doesn't support efficient billing within shorter spans of time, so you can have the cash flow to run your organization. So that's just a methodology comment. My other comment was when somebody testified on room and board, the methodology that they used to calculate the rate, at least a couple of years ago, was they took a percentage of what HUD would pay for assistance for somebody that's low income, which is really what it is. And what they did when they assumed it a couple of years ago, they took the window of the highest HUD income that would qualify to give the lowest percentage of reimbursement, and that was a couple of years ago, and I don't know how they're doing it today, but if they could come up with a process that is more fair and equitable, because a lot of these people's income isn't at the high end of what somebody would make, it's at the low end of, because most of them don't work. So if they could look at that also, that would be very helpful. And I have really nothing else because everybody else has been more than adequate. So thank you for the opportunity.
Okay, thank you, Pete. Okay, it looks like some people might have kept their hands up. If you could lower your hand before we go on to the next question. Thank you.
Okay, great. So thank you so much, everyone, for your comments. We really appreciate it. And we also really appreciate when you just say you agree so that we can get as many people in as possible. Our next question is really looking at what incentives are created by the payment methodology or are not created by the methodology. So do you feel like the incentives are there for quality of care, access to care, primary and preventative care, integration of care coordination, reflect the way members use services, and provide an opportunity to avoid abuse and fraud? So we'll go ahead and ask everyone to please raise your hands if you would like to comment on this section, or if you can't raise your hand, once again, go ahead and message Julian in the chat and she can manage it from there.
Okay, thank you, Julia. The first person I've got is Catherine.
Hi, again, this is Catherine Thibodeau. I'm going to speak to Section 50, ICF IDD services. Being that this service is cost reimbursed, pretty much your expenditures within that are reasonable and customary are reimbursed. It does provide some incentives, certainly for access to care. There is no incentive necessarily to cherry pick or to not provide services to the most challenging individuals. I think I spoke and then my colleagues spoke about the challenges of supporting people with complicated needs. And I'm just going to say it like this. It is imperative that the state of Maine figure this out. We in the ICF program support people with high complex medical needs, high behavioral needs. We have a rate methodology that supports this, but outside of those 192 individuals, there is not a rate that supports it. This is not a program that is in any way expandable by the way that it is set up. So access to care is limited, as there's no way to increase or certainly get reimbursed for an increase in program size. So whether the answer is to allow for more access to ICF services or to better improve the rate methodology for Section 21 group home setting, that's for somebody at a higher pay grade than I to answer, but it is absolutely the most important thing to our service delivery sector right now. And I would be remiss not to emphasize that point over and over again. So abuse and fraud, I will just speak to that real quickly. I think I said this already. This is a very administratively burdensome program. We are required to document and account for every cost. Therefore, that really does, and then subsequently audited on that each year. So that does reduce or that does improve the avoidance of abuse and fraud. And that is all I got to say.
Okay, thank you, Catherine. Next up, I've got Rebecca.
Good afternoon. Thank you again for the opportunity to provide comments. Rebecca Emmons, Executive Director for Mobius, based in Lincoln County, and providing comments specifically to community supports as well as work support services in Section 21 and 29. The lack of an adequate rate to cover the costs of providing the community and work support services to individuals with challenging behaviors is directly tied to the quality of care and the access to care that these individual members receive. Without there being some type of methodology that acknowledges the individual and their unique needs, providers cannot retain the specially qualified staff and train them adequately and enable effective interventions on behalf of that member. Per the recently published study by ODES and OMS titled Services for Persons with Intellectual Disabilities or Autism and Adequacy of MaineCare Reimbursement, a value-based purchasing design should be developed and implemented that meets the needs of individuals with challenging behaviors. And I strongly encourage that this design not be specific to one type of setting in which the individual receives services, but that true rate for that individual's needs follows them regardless of service setting, meaning into community and work support services, or that there be some type of methodology that acknowledges the individual member's needs are not specific to a setting, but are part of who they are. Many members require intensive skill building before practicing or generalizing a skill set in a community or work support setting. If there's a lower rate or a methodology that indicates a facility-based service is less than a community-based services, providers will be incentivized to choose clients and conduct intakes with clients who do not need the facility-based services, meaning those who perhaps are less complex or less challenging. I would strongly encourage that the methodology recognize the individual member served and not be specific to the setting in which the service is provided. Similarly, access and quality of services for work supports. There is widespread inequity across the state of Maine for individual members to access long-term work supports. The state has implemented a new process with specific vendors providing job development services. However, we are finding that often the job development service is looked upon as a quick transaction rather than a full 90-day commitment, and the movement towards work supports long-term services is very quick, but there's not an adequate workforce. Similar to comments made before, there should be some type of method specific to the staff training and staff training time it takes to bring someone up to the level of quality services that are needed to sustain long-term employment and support that effort. Thank you for the time.
Thank you, Rebecca. Next, I've got Eric Muckey.
Yes, hello again. This is Eric Muckey from Sweetser, serving Section 21 home support. So I just wanted to point out that the current system really focuses on staff and clients as interchangeable and as sort of a commodity, whereas different clients will have very specific needs and will require different kinds of staff and staff trained to a higher level in some cases than a standard DSP, such as with CRMA certifications for delivery of medications and other different issues. So I just thought that a true per diem with a census or population-based model could better account for the individual needs of the client as opposed to just a per hour flat rate across the board. And that's all I had on that. Thank you.
Thank you, Eric. Next, I have Andrew.
Hi, sorry, did you say Andrew?
Yes, I did.
Okay, so again, Andrew Cowan, Chief Financial Officer, Jonathan Murphy Homes, speaking on Section 21 and 29. Does the payment methodology create the right incentives for quality of care? Obviously, the answer is no. The rate provides that we get reimbursed provides for a wage less than minimum wage. I'm a true believer that you get what you pay for. You're paying for something that's less than minimum wage, so the quality of care is going to suffer because the talent pool that we have to choose from is diminished. Access to care. We are about to put on the market 3 facilities to sell, representing 10 beds. So access to care under the current system is diminished because we're obviously contracting. We're not expanding. We're not accepting any new clients because the numbers don't add up. Integration of care. The current system, if a resident refuses to go to day program, which is their right, we now have to staff for that person in their home. There's really no mechanism to trigger extra funding for that person's refusal to go to day program. If we were able to bill the day program rate for the care in the home, that may make sense, but right now we're not able to. And that's all I have to say. Thank you.
Thank you, Andrew. Next I have Ray.
Hi, I just wanted to, again, thank you for allowing me to comment. And I wanted to say that I endorsed what Catherine said, what Rebecca said, and what Eric said. One more thing is in Section 21, under consultative services, if we are truly going to want to address people with behavioral challenges, the consultative services have to be hours that are actually going to make a difference. Right now, they're limited to 16 and a half hours a year. And where children that have the same needs have well over 150 hours. The 16 and a half hours a year per person for consultation represents only a functional behavioral analysis, It doesn't include the type of training that's necessary to do it. And when you have such a high turnover rate, you're constantly training and retraining. So I think consultative services has to be a part of this as well. Thank you.
Okay, thank you, Ray. Todd, did you want to speak?
Yes, thank you. Todd Goodwin again, CEO at Jonathan Murphy Homes. Briefly, I would say that I won't go bullet point by bullet point on the screen here, but I would say from my vantage point, the sort of overarching answer to the question in each of those bullet points is no. I'm reminded many years ago when the state of Maine was fortunate to receive one of the first strategic innovation grants, SIM grants, can't remember what the exact acronym was, a grant to seed the development of alternative payment models and value-based purchasing in the larger healthcare sector and then the behavioral healthcare sector that led to many models that are fairly common these days. I'm reminded that at that point in time, the state did have the option to identify the persons with intellectual and developmental disabilities as a chronic condition that would merit attention in the realm of value-based purchasing and new models that get at integration of care coordination, all that kind of stuff. The state elected not to do that. So I, for one, am thrilled to see this as being a area of focus. And I would just note that when it comes to care coordination, which in my understanding and estimation is key to integrated care, I'm reminded that in the Section 21 agency home support service specifically, as well as other service areas in the IDD world, That's what we do. So we are eminently qualified and prepared to coordinate care, because that's what we do all the time when we recognize that today we still, in our sector, exist on the fringes of the larger healthcare economy. So, you know, if there was some IDD home structure, something equivalent to a patient-centered medical home, a behavioral health home, something like that, I think that we would be well prepared to respond to that. And I'm enthused to see these concepts being presented. So thank you.
Okay, thank you, Todd. Next, I have Nate Miller.
Hi, thank you. My name is Nate Miller. I'm Senior Program Director at Spectrum Generations. We provide a variety of different services under various MaineCare sections. What I wanted to mention, though, was adult day services. I mentioned it this morning, but this might be a better place to discuss that, as it's funded by 21 and 29. So Spectrum Generations has really done a great job at holding on to day programming. But because of the payment methodology that's in place, it has prevented access to for a lot of our consumers across the state. The last time I checked in Western Maine, 3 counties, Androscoggin, Oxford, and Franklin counties, there wasn't one day program available. So maybe that could be, that aspect of access to care could be addressed through payment methodology. I think there's also a question about how members use services when a member is eligible for multiple sections. It's questionable whether or not they get into the right section. And that's all I have to say on those bullet points. Thank you.
Thank you, Nate. Next, I have Anne Marie. 1 second, let me unmute you. Okay, Anne Marie.
Hi, thank you. Anne Marie Mayberry, Executive Director, GMS again. Just a couple of other points that people have already made, several of them, but to speak to the abuse and fraud, I think that the payment methodology does not create the right incentives. The methodology is having us hire people at below minimum wage, and so we're hiring people that are not. I guess they're people that need a lot of training and a lot of support to work with this population, and so the methodology does not allow us that leeway to or the ability to train and to work with people that are coming into this field, because it is an entry level, and so you are going to have a lot of people that would be good for the field, that would work well with the people that we support, and then you're going to have people that aren't, that are there for a paycheck, and when you have such high turnover and we have such a workforce shortage, agencies are desperate, and so then that can lead to abuse. And part of the other issue is the background checks. The methodology does not reimburse agencies back for being able to have to do the significant amount of background checks that are required to keep the consumers safe. And so sometimes the response that we get is delayed, and that whole background piece needs to be tweaked a little bit. Also, the services for quality of care and the access to care, the medical professional field is just not there. It's difficult to find medical, dental professionals that are willing to work with this population because of the low reimbursement rate. And so we have several consumers that wait months and months on dentists on list for dental work. We have people that do diagnose that need psychiatric counseling, and there's nobody in this. I shouldn't say nobody. There's not many people in this field that can work with the IDD population, or are willing to work with them, or have the expertise to help people with, behavioral challenges, or people that are transgender, or people that are, just that have significant psychiatric issues. So that's, I think, is a fault of the methodology. It doesn't create any type of incentive for people to want to work in this field to help better the lives of the people that we support. And again, the minimum wage is an issue here, that the reimbursement is not able to meet that minimum wage for the state of Maine. So then we, as well as somebody else that spoke earlier, have closed several of our programs because we're just not filling vacancies. We just don't have the ability to staff that at this time. But thank you.
Okay, thank you, Anne Marie. Next, I got something in the chat that Joe from BFLI would like to talk. It looks like he may be a call-in user. So again, I'm going to unmute some batches of call-in users to see if I can help identify who he is. Joe, can you respond if you hear? Okay, I'm not getting anyone there. Joe? Okay, I can't seem to identify Joe. So again, we may need to use the chat or the email address that will show again at the end of the presentation to record the comments. Next up, I've got Mike Stair.
Hi, this is Mike Stair calling from Care and Comfort. We are a Section 21 and 29 provider of home services, community services, and day program services. And I certainly want to echo many of the comments earlier that were earlier made, and I won't repeat all of them other than to say that they were right on target, especially regarding the fact that the model that's in place for Section 21 and 29 rates are certainly impede both the quality and the access to care with respect to the rate structure and the wage base for DSPs. Just to correct a statement that was made earlier. Yes, there is a day program that's offered in the Androscoggin, Franklin, and Oxford County area, not getting into any marketing or anything like that, but Care and Comfort offers a day program in the Wilton area, and we are accepting referrals. So thank you very much.
Okay. Thank you, Mike. I am not seeing any other comments or hands up at this time.
Okay, brilliant. And so we'll move to the next question. Question number 3, this one is a little bit challenging at times to answer. It's really about equitable payment methodologies and looking at whether you feel like you're looking across within your service area, are providers generally treated equitably in terms of payment methodology, looking at how fee schedules are determined and updated. Is the administrative burden fairly consistent, incentives for quality and access? So go ahead. Thank you. Are already raising your hands or letting us know in chat if you'd like to speak.
Okay, thank you. First, Anne Marie, is your hand still up? Would you like to speak on this issue? Oh, apparently not. Okay, next I've got Pete Plummer.
Hi, thanks. I'm going to touch on the equitably part of this question, and it gets back to the true per diem discussion that came up in the last presentation. I mean, some of these issues, hit many different areas, and the fact that of the amount of administrative burden that we need to put in to call this a per diem. Section 21 rule calls it a per diem, but it's not. Somebody said it's really an hourly rate. It's really an hourly rate with a cap. you can bill up to a certain amount of hours that you spend. But once you hit that, no matter what the need of the consumer is, you will not get paid it. But if you bill the hours that, under what you're approved, then you have to reduce your per diem bill if it's less than 92.5% to whatever those hours add up to. So it's a lot of work. And when I look at across the spectrum of other healthcare providers in the state, when they get paid a per diem, they get paid a daily rate for the services that are expected. And sometimes they have to staff under, and sometimes they have to staff over, but it's the daily rate. They know what it is, and they can manage that. And we're not treated equitably because we have to manage the hours, not the care, to hit the window. So we take our eye off what a per diem is and how it should be. So the language in the rule is incorrect. It's not somebody used the word true per diem earlier, and this is not a true per diem. It's a misnomer within the rule, and so I wish they could either change the rule so people understand that it's not a per diem rate, because it really isn't. And I've been on, and so I ask for a true per diem. It would help many different administrative levels. It would make the service equitable when it comes to billing and staffing. It's just to make a lot more sense. But thank you.
Okay, thank you, Pete. Next, I have Andrew.
Hi, Andrew Cowan, Chief Financial Officer, John F. Murphy Homes. It's not equitable, and I'm specifically looking at Section 29 day programming. The quarter-hour rate is $6.53. The person has a medical add-on. The billing rate is $8.05 per quarter hour. When I look at the rate for elderly and adults with disabilities, the rate is $14.03. The numbers are right there. It's completely inequitable. If my adult with autism was elderly, they'd be getting $14.03. Is someone who is elderly and disabled more challenging than someone who is not elderly with autism and behavioral challenges? I don't think so. It's not equitable. Thank you.
Okay, thank you, Andrew. Next, I have Eric.
Yeah, this is Eric Muckey from Sweetser for Section 21 home supports. I don't believe it is equitable, primarily for the large amount of fixed costs, especially just the room and board, which includes things such as vehicles, transportation, food, supplies. Obviously, there's repairs and just the overall maintenance of the home. And I just don't think that it's equitable, because when we're built on a hourly rate, which, as we've kind of discussed quite a bit here today, it's not really a per diem, it is a per hour, and there's just a lot more that goes into it. So when we look at the rate table and we compare per hour for different community supports versus home supports, I just don't feel like the home part and providing a safe and supportive home is being considered. Thank you.
Thank you, Eric. Next, I have Catherine.
Hi, this is Catherine Thibodeau speaking again. Again, I am speaking on Section 50, and I would like to make the point for Section 50 that in comparison to other provider types, oftentimes we are compared to a traditional nursing home. And I do not think that that is an appropriate comparison. And I want to be sure when the rate methodology is being reviewed that this point is made that ICF ID services is only a Medicaid service. So we do not have any private pay, and we do not have any Medicare or skilled days. And therefore, it's not a program where you can make a profit on it. So therefore, the rate is the rate, and it's just important to recognize that it's a 100% Medicaid provided service. That's all I have on that.
Thank you, Catherine. Next, I have Anne Marie.
I just can't get my hand down in the chat, so I'm.
Oh, no problem. Okay, then I have Ray.
Hi, thank you again for letting me talk. There are certainly things that are equitable, and there are things that are not equitable. First off, one of the most obvious inequities is the fact that for whatever reason under the sky, when working with people that have challenging behaviors, the state authorizes you more hours to work with the people. And a lot of times, those individuals require a 2-to-1 staffing in the public. And I've known agencies to have 3-to-1 staffing. The inequitable part here is the fact that once a person has reached 168 hours in a week, the rate for that person to serve that person is reimbursed at a rate that's 13% lower, which that's not fair. Secondly, the certain programs have bed hold rates, and currently, if you have more than 2 people in a group home, the state doesn't, you don't get a bed hold rate, period. But if there is a situation where you have 2 people in a home and one is gone, you can apply for an augmented rate for that person while they're gone, but they don't allow for it for anything more than a 2-bed. In Florida, a person could leave a group home for 15 days a year, and you could hold that you could be assured that you would get that per diem. And again, the last thing is, I think that this is already been stated, but in a different way. The room and board rates, like Mr. Cowan said, they've over the years they have gone down every year. When we work with people that have behaviors, they're kicking walls down, they're putting holes in the building, they're breaking glass in vans. My workers' compensation rate goes up. None of this is taken into consideration. And licensing will come in and tell us that we have to fix these things. So that's all on our dime. So there's no incentive to take people with behaviors because there's no reimbursement methodology to pay for it. There was something else I was going to say along that line, but I think you get my point. There is no money to serve people from a room and board perspective for all of the costs that go into providing services for your moderate for an individual with moderate behaviors, let alone an individual with significant behaviors.
Okay, thank you, Ray. I'm not seeing any other hands or, oh, got one more hand. Next up I have Todd.
Hi, sorry about that. Didn't mean to put you on the spot there. I thought my hand was raised. Todd Goodwin again, Jonathan Murphy Homes. Just a very brief comment on that Andrew made regarding the inequity between, as an example, day program rates on the elder side versus the IDD side. I just would make the observation that not only is that an issue of inequitability, however you say it, you know what I mean. Not only is that inequitable, I would submit that it is also potentially discriminatory. So I think it's important to note that discriminatory against persons with intellectual and developmental disabilities. Thank you.
Okay, thank you, Todd. I'm not seeing any more hands or any more comments.
Okay, great. So let's move on to the next questions. It's actually two questions on one slide. So these are the questions about value-based purchasing and the administrative requirements. So is the methodology consistent with value-based purchasing? Is it consistent with any other value-based purchasing approaches that you have in place through other payers, or that recognizing that these are largely waiver services or ones that you've seen similar models or that you've encountered? Are there administrative requirements like coding, billing, and reimbursement that MaineCare specifically places on you that you feel are burdensome? So if you could go ahead and start raising your hands to respond to this question or messaging in the chat.
Okay, thank you. First, I've got Anne Marie. Okay, then I've got Pete.
Hi, and this is Pete Plummer from Woodford's Family Services. I want to talk about the administrative burden with billing under Section 21 agency home supports. People have touched on it, a bit, so I won't dwell on it for too long. But you guys can't leave without knowing that this is it is the most administratively burdened program that we operate at Woodford's Family Services. Just the we looked around. Here's a great example. We looked around for an electronic health record, that would also do billing for us. And we looked and scoured and looked at lots of different software vendors, and we could not find one that could create a system that would bill for the services to MaineCare. So we have to maintain our manual Excel-driven data by program, taking information out of payroll, because that's how we're going to be audited, to be able to submit a claim to figure out how many hours an employee spends in what program. If one employee goes to multiple programs, they have to clock in and clock out and fill out their time card, and we have to track that. And it's really burdensome. It's so burdensome that clinical software can't even figure out how to do it. And then we bill monthly. It's really got to change. Going to a true per diem, you wouldn't have all of those administrative burdens and headaches, and it would save agencies money too. It would save the state money too when they come and do their audits, and it puts providers at risk in the state of Maine at risk by creating a system that is so complex that clinical software providers can't even figure it out. So if you change one thing, work on that, please. Thank you.
Thank you, Pete. Next up, I've got Catherine.
Hi, again, this is Catherine Thibodeau. I am going to concur with Pete on Section 21 and 29 services and the challenges of finding an EHR that can handle those complexities. I would like to comment also on Section 50 on the value-based purchasing. I think while it is an interesting idea and concept, it would be a challenge to carry this out in this population because quality is a little bit hard to define in healthcare terms. Oftentimes it's, reduced hospitalization rates, reduced infections, and with this population, as I had spoken to earlier, with their intense, the totality of the individual supported in this program's intense medical needs, it is not often not possible to avoid certain things, and there's limited understanding and knowledge of the complexities of each of these individual diagnoses and comorbidities that the people supported this program have. So that would need to be taken into consideration. Thank you.
Okay, thank you, Catherine. Next, I have Eric.
Yeah, hi, this is Eric Muckey with Sweetser, Section 21. So as the value being defined as quality over cost, I would like to see a quality metric that's more from the perspective of the client satisfaction and the overall, and some other folks have already talked about this, but just a better metric for performance as opposed to just having staff and just sort of, having bodies in the house. I would like to see something a little bit better towards reaching our goals. As far as the administrative requirements, the ability to bill as an agency that has multiple homes, we have to treat each home as a unit. I think it would be much easier on providers if we were, for those of us with multiple homes, if we could bill sort of more as a single entity, as an agency, as opposed to billing as so many kind of underlying units and underlying clients as well. And so another issue as far as the burden is the constant reauthorizations as clients go in and out of day programs, which is the community supports. And I would like to see something a little bit more linear and just something that's a little bit more longer lasting. So as the authorizations change, we don't have to constantly deal with reauthorizations. That was all. Thank you.
Okay, thank you, Eric. Here we go. I've got Todd next.
Hi, thank you, Todd Goodwin, John F. Murphy Homes. I would say no on 4 and yes on 5. Leave it at that. Many others have spoken to that. I would just like to note in the realm of value-based purchasing, just to put out there an appeal, much like my friend Pete Plummer did. I'm conscious of, and I'm probably not going to get this right, so bear with me. There was a report issued recently. I think the department put it out on the adequacy or lack thereof for behavioral support issues. I think it was like a 2 or 3 page report, and I believe Myers and Stouffer were referenced in there. This activity that we're in and all of that. And I'm conscious of the fact that that report gave a suggestion of what a value-based purchasing model might look like in the IDD sector. And if I recall correctly, there was specific reference made to BCBA services, which I would endorse all the way. But I would just note and ask that you all recognize that, putting something forward like that, let's make sure that it comports with the various and sundry regulations that affect our work. I think specifically of the behavior regs. We operate a number of schools for kids with autism and other disabilities, and BCBA services are a central feature of our programming. And our kids folks recognize straight out of the gates that there's going to be all kinds of conflicts between real rigorous BCBA services in an adult population as it relates to the behavior regulations that affect our sector. So I just wanted to note that and hope that we're paying close attention to the various and sundry tentacles that exist around us beyond the rate models themselves. Thank you.
Okay, thank you, Todd. I'm not seeing any other hands or chat questions right now.
Okay, great. So that you can go ahead and move to the next slide. That pretty much wraps up our questions that we had. I just wanted to, I'd like to open it up one more time at the end. If there was anything that you think is really important for us to know that has not already been mentioned, you can either send it to us in email at ratesettingeval@maine.gov, or if you want to put your hand up, this is your one opportunity to kind of wrap up here if there was something that hasn't been said that you would like to say here.
Okay, I've got Catherine.
I would just like to, even though it's a reiteration, but what Todd just said about taking into consideration other requirements, I think that's important in any decision making across the board, as there are, licensing requirements, behavior regulation requirements, just to name a couple. Across section 21, 29, and 50 that need to be taken into consideration when you are analyzing the rate methodology for these services. Thank you.
Thank you, Catherine. Okay. I'm not seeing any other comments here. Oh, here, I'm getting a couple now. I've got Ryan.
Yeah, this is actually Joe Kuhn, Director of BFLI, but I'm on with Ryan. I really appreciate the process. I think it's a wonderful thing we're finally doing. One thing, many of the things I think have been mentioned that I would raise concerns about. We're real concerned about Section 21 per diem. Again, some of the things others have said. We take on someone exceedingly challenging. That person requires more than 168 hours. We're penalized with a reduction of $3 per hour for every hour over 168. Our workman's comp is going up because our folks are getting hurt. Some of these folks need real expensive wheelchair vans. We're told everything's included in the rate, but the home down the street has a Toyota Corolla. So, there's a lot of inequities there, and I really hope we can get through them. We have great people. They want to consider this their career. We're now telling them they're health professionals and they're going to be treated that way as we come out the other side of this pandemic. We've got to find ways to attract and retain professionals. And some of that has to do with the right amount of reimbursement. Value is not the cheapest service. And when we start comparing and saying, golly gee, Maine is more expensive than other states. Burns and Associates shared that a number of years ago, and we sat down and we did an analysis across the country. And what we found was, there were states like California, Arizona, Florida that had access to large immigrant populations, and they were hiring a lot of those folks. I have nothing against that, but we don't have that workforce in the mid-coast. We can put ads out for months and not have an application. We have no choice but to pay incredible amounts of overtime. Overtime in the last rate analysis wasn't even factored in as proposed as a cost. So, and the whole idea of per diem, rewarding or punishing based on whether or not you have adequate numbers of employees is to me ludicrous. I'd rather get a true per diem, be able to go out and attract and retain people at a competitive wage, and figure out a way to get it done without my hands being tied by rules like that. But thank you so much.
Okay, thank you for your comment, Joe. Next up, I've got Anne Marie. Let me find you here. Okay, Anne Marie.
Hi, thank you. And again, I'm sorry about the hand thing. Just in closing, I just want to, again, this is Andrea Mayberry from GMS, and I'm speaking on sections 21 and 29. The rate methodology must take into consideration the HCBS regulations coming into regulation in 2023, which is person-centered and person-focused. So whatever methodology the state comes up with, it needs to take that into account, as well as perfect example, the pandemic that we're in. And I was just on a conference the other day and listened to an epidemiologist that said that this pandemic will be with us probably for the next 4 to 5 years. So knowing that nursing is going to be critical in keeping people safe and healthy. So making sure that there's adequate funding for our nursing staff, for qualified trainers. The answer is not always throwing more hours into a program. The answer is hiring the right staff and the qualified staff and people that you can train. Making sure that there's enough training money in the methodology, in the rate methodology as well. And another one that's come up over and over again is room and board. If you want access for people and for people to have choice, you have to have agencies that are able to afford buildings in areas across the state of Maine, and that needs to be we need to be reimbursed for that service. Again, thank you for listening to all of our comments, and I appreciate the opportunity to speak.
Okay, thank you, Anne Marie. Next up, I have Ray.
Yeah, thank you again. One thing that was not mentioned is transportation in the programs. The cost of transportation in day programming and in the group homes is part of the rate. And I'm glad that Anne Marie spoke ahead of me, because as we go to the new community settings rules, we have the oldest median age in the state of Maine, and that's also reflected in the people we support. And I have a good third of the people that we serve require handicap vans. And handicap vans are expensive to maintain, and they need to be a portion of the rates that are associated with serving people that require that level of support. The same goes for adaptations in group homes. Right now, the only way you get reimbursed for making a home compatible for an individual with a wheelchair is if that person owns the home, and there's no methodology to get reimbursed for that. So, that is something that is of significant concern to a lot of different agencies. Mine, I think of the agency in Lewiston or Auburn, the Social Learning Center, where the vast majority of the people there are actually in wheelchairs themselves. Getting them into the community is going to be very expensive. So that's all. Thank you for listening to me.
Thank you, Ray. Next, I have Eric Barry.
Can you hear me?
Yes, we can.
Hi, this is Eric Barry. I'm a financial analyst for Penquist Cap. And thanks for giving me the opportunity to speak. I just wanted to touch base on one item that I don't believe has been talked about yet, and I noticed it was part of the subject when the email first came out about these sessions with the acquired brain injury world. Section 18 shares the same challenges as 21 and 29 with the rates, the reimbursement rates, and what we're having to deal with challenges and other costs related to homes that some other folks have touched base on. One area of concern when thinking about the methodology of the rate is back to at the beginning of this pandemic, I believe a Burns rate study came out around Section 18 and how there was a possibility of changing to a model where it would be based by number of clients in the home, and also factoring in what level of care that acquired brain injury clients have, whether it be level 1, 2, or 3. And it created a situation where I think if it were to go to that, it would create more of an administrative burden of trying to figure out what dynamic would work in each home and what homes we have. And it would be more focusing on that rather than focusing on the total quality of care for the clients. So as far as making it equitable, that model might not necessarily work or would not work after doing further due diligence. So I just wanted to make those points that Section 18 shares the same challenges as 21 and 29, and just to take that into consideration with the methodology. Thank you.
Thank you, Eric. I'm not seeing any more hands or questions.
Great. So thank you everyone so much for joining us this afternoon. We really appreciate you taking the time to come and speak to us. Once again, if you think of something later that you think we need to know, please don't hesitate to send an email to the ratesettingeval@maine.gov. And I hope that you guys have a lovely rest of your day. Thank you.